Good morning, good afternoon, and good evening to everyone, wherever you are and whenever you're watching this session. My name is Stephen Leon, and on behalf of the Education Committee, I am introducing a new session regarding variations in care. This session was initially proposed by one of our APSA members to the Professional Development Committee as a session to discuss why there are significant variations in care between regions and between institutions. Sometimes there are no data leading to these differences in care. And other times there are actually too much data that support any type of care which lead to differences. The purpose of this session is to try to make sense of these variations in care and come to some conclusions for you to incorporate in your practice. This year's topic is on gastroesophageal reflux disease. I know, not a very controversial topic. This topic, along with appendicitis, is one of those topics that nearly every pediatric surgeon has an opinion on, and a lot of times it's a strong opinion. So the first question is, does variation exist among pediatric surgeons in the management of gastroesophageal reflux disease? Well, as you can see by this slide, the answer is yes. These data are from the FIS database, show the number of fundoplications performed at children's hospitals across the United States in 2019. This number ranges from 0 in some institutions to over 250 fundoplications in other institutions, and these were just performed over this past year. So to address these variations in care, the Education Committee has put together a panel of experts to discuss the diagnosis and management of gastroesophageal reflux disease. So sit back, relax, and enjoy this session. One last thing, please participate by chatting or tweeting any questions during the presentations. I will now turn it over to Eunice and Jonathan.
Good morning, good afternoon, and good evening, everyone. My name is Eunice Huang. I'm a pediatric surgeon at the University of Tennessee Health Science Center in Memphis, Tennessee. Jonathan Mizell and I are thrilled to have the privilege of moderating this session on variations in care on the topic of gastroesophageal reflux disease. We hope that this will be the first in a long series of future sessions on topics along this theme. So let's get started. For this session, we have recruited 5 talented physicians and surgeons who have deep but different experiences with caring for children with reflux disease. Since it's a really large and complicated topic, we have broken it down to 2 segments. Tonight, we'll be talking about workup, medical and surgical management of patients with reflux disease. Next week, we will talk about patients with other comorbidities. Please feel free to send in questions via the chat function, and we will incorporate these questions and comments in our live discussion with our panelists towards the end of this half hour. So let me start by having my co-moderator and our panelists introduce themselves.
My name is Jonathan Mizell. I'm assistant professor of surgery at Emory University School of Medicine and Children's Healthcare of Atlanta.
My name is Matt Clifton. I'm an associate professor of surgery, also at Emory University Children's Healthcare of Atlanta.
Hi, everyone. I'm Benjamin Sandejas Mamard. I'm an assistant professor of surgery at Harvard Medical School and work at Boston Children's Hospital.
Hi, my name is Rachel Rosen. I'm a pediatric gastroenterologist and associate professor of pediatrics at Boston Children's Hospital, and I'm director of the Aerodigestive program.
Hello, everyone. This is Sharif Emil. I'm a pediatric surgeon at the Montreal Children's Hospital and the chief of the pediatric surgery service at McGill University.
Hi, I'm Tim Janselowitz. I'm an associate professor of pediatric surgery at University of Tennessee Health Science Center, LeBarnard Children's Hospital.
Thank you all so much for being here with me. We're going to start off with a very standard case. It's a 3-month-old neurologically normal infant who presents with severe reflux. He has irritability, recurrent vomiting, and failure to thrive. Formula changes have not improved their symptoms. The patient is referred to CU to discuss surgical options. The infant is on the maximal dose of an H2 blocker, which has had minimal effect on the baby's symptoms. So I'm going to start off with Rachel, who is our pediatric GI colleague. My question to you is, should every infant first see a pediatric GI physician prior to a surgical referral?
That's such a good question. That's a pretty hot topic for us because access to pediatric gastroenterologists is limited. We recently drafted a guideline for the management of gastroesophageal reflux that actually targeted both pediatricians and gastroenterologists for pediatricians who don't have access to gastroenterologists. I think in a perfect world, it would be terrific if everyone saw a gastroenterologist to get some workup prior to Nissen, but we recognize that this is definitely not possible in certain areas.
What would you think were some diagnostic tests?
so variable depending on which region you're in. And I know there's studies. What we recommend is, as you mentioned, is this child had formula changes, but it's really important to know what those formula changes are. So we consider that patients need to be either on an amino acid-based formula prior to considering nisin is what we recommend, and that's the super broken down formula. So that for us would be number one, and a thickening trial would be number two. So both of those things for us would need to be done before we would even think about diagnostic testing. If both of those fail to improve symptoms, then we would think about imaging such as an upper GI to look at for anatomic reasons why. So I think at minimum, we would recommend some therapeutic trials and for sure some imaging to make sure there's nothing anatomic, especially in this little baby who's really failing to thrive. We probably would also get some blood work done to make sure that we're not missing something metabolic. And then lastly, in this age group, we always worry, is vomiting a first presentation for something neurologic? So many times we see extreme fussiness as the presentation that has been blamed as being reflux, but in fact, it's something neurologic.
So let's say that you're in a situation where any test you want to get is available.
That's the biggest problem, is that we have no great gold standard for how to diagnose reflux. I think most of us would use a catheter-based method, such as the pH-impedance probe, as the gold standard to make sure that the symptoms that the family is seeing is actually correlated with esophageal events. And as we talk about in older kids, this is particularly important because now we have new diagnoses such as functional heartburn and reflux hypersensitivity, where the pH impedance probe really makes a difference. And especially in infants, because infants have so much non-acid reflux. If you just do a pH probe, you'll miss all of the non-acid reflux events. If I have to commit, I'll go with pH impedance probe.
Rachel, I got a quick question for you. Can you talk a little bit about the limitations in the pH probes?
There are for sure some things that interfere with the reliability of these tests. So if you have an underlying motility disorder, such as esophageal atresia or achalasia, for example, your test is going to be much less reliable. And the sensitivity of detecting esophageal events, it's pretty good. It's in the upper 80s. There are some things that interfere as well besides motility disorders. If you're an air swallower, if you have a hiatal hernia, so if you don't know where that catheter is being placed, you could be sitting in a hernia. But for sure, impedance is the gold standard for diagnosing non-acid reflux.
I'm going to open up the floor to our surgical panelists. How would you guys work up an otherwise neurologically normal baby with very severe reflux?
When we get consulted on a baby that's having bad reflux, I think the first question that we all want to know is the reflux actually pathologic? So it's really a patient that has bad reflux that's having some sort of sequela as a result. So they're having either repeated aspiration pneumonias or point of view, the most critical thing that we do up front is take a really detailed history and physical from the person that is feeding the baby the most. Because I think that's really what's essential here. With the study I usually choose to start with is an upper GI. And that gives you a lot of information. If you find either an anatomic or emptying problem, that's going to lead you down a different treatment path. More likely than not, what you'll find is normal rotation, normal gastric emptying. And so then you're really left with the question of whether or not the symptoms that you're seeing correlate with reflux or not. Oftentimes, for like a 3-month-old, what we'll do here is simply do a trial of post-pyloric feeds, and the symptoms totally resolve, then I think that's a very good indicator that an anti-reflux operation is going to be effective at solving the child's problems. If, on the other hand, you successfully accomplish post-pyloric feeds, but you still see the baby grunting, desaturating, having altes, or arching their back and fussing, then I would argue that it seems like then you need a little bit more of a workup before you would proceed with any sort of surgical intervention.
Tim, so you did a great review about this topic.
We, at our institution, we will get an upper GI as part of the preoperative workup to rule out an anatomic problem or something that's not related to reflux that's causing the symptoms. But the data that we examined for that study in 2017 showed that there really is no evidence that an upper GI contrast study is useful in the diagnosis of reflux. And all babies will have some degree of reflux when you inject a high bolus of contrast in the stomach. And generally, I don't like to get a pH probe study in infants because I really don't think that it changes my clinical decision making. If the symptoms are clear and you've spoken to the caregiver, primary caregiver, and there's a clear problem with reflux, then I don't need to have a pH probe study to push me towards doing an anti-reflux procedure.
A lot depends on accessibility to what you have in your area. And I think this is one of those things, if you put 3 gastroenterologists in a room, this is what we fight about. It's largely when do you test versus when do you treat empirically. The reason that we wrote into the guidelines that it was okay to try a 4 to 8 week trial of a PPI before any testing was for people who don't have access to testing. Impedance was added as an important diagnostic test for exactly what everybody else said, which is the importance of the test is not to diagnose the amount of reflux you have, it's to diagnose if your symptoms are associated with reflux events. I did just want to bring up one other point of barium imaging because the video fluoroscopic swallow studies are important to diagnose mimickers of reflux. And in infants, the biggest thing that we see that looks like reflux but isn't reflux is aspiration during swallowing, because these babies are coughing and choking and sputtering and have lots of gagging and retching because the food's going into their airway. So just to summarize, PPI trial is there if you can't test, but if you can test, our goal for testing is to correlate with symptoms.
Rachel, ask you to run through some of the studies again so we could kind of hone in on this a little bit.
I actually put up a list of a variety of different studies that we think about. And again, a lot of this is really to rule out other masqueraders that look like reflux. But I think some of them are very helpful as gastroenterologists, and I'm sure from your perspective as surgeons as well. So we talked about the impedance probe, and we talked about the upper GI, and we talked about the video fluoroscopic swallow study. The gastric emptying scan for us is important because we're using more Botox to the pylorus to treat patients with severe vomiting that have nutritional compromise, for example, or in kids that are retching a lot that you may not want to do a fundoplication on because they're retching so much. So we often will get a gastric emptying scan to see if there's delays in emptying, and if so, that would push us either to think about pyloric Botox or to put a motility agent on.
We often will have patients that have had one of these tests ordered before the surgeon is consulted. My understanding of the literature is that it's not a great test or necessary test prior to what would a pH probe study look like in somebody with a gastric emptying problem?
And we actually did a study in lung transplant patients. We didn't show any correlation between delays in gastric emptying and the impedance study. So it's definitely not the correlation that we expect. You know, endoscopy, I would say in the past hasn't necessarily been important in the pre-fundo workup, but now because eosinophilic esophagitis is so prevalent and you don't want to wrap a kid, I would argue, until you get the eosinophilic esophagitis under control in case that's what's causing their symptoms, we do endoscopy to look for that. High resolution esophageal manometry with impedance is really important, not only because you don't want to wrap a kid who has a primary motility disorder. So when we think about people that aren't good candidates for a fundo, it's kids that are ruminating who will blow through their fundo. So now every patient that we're worried about rumination, we will do a high resolution manometry study before considering fundo. Flip intraoperative at the time of a Nissen to see how distensible the Nissen is. But it's also great for assessing post-fundoplication complications. And for us, a post-pyloric trial is really important because as we teach our fellows, if you don't respond to a post-pyloric trial, you're not going to respond to a Nissen. So I think all of those are in our toolbox for the evaluation.
Rachel, I'm interested in the last point you have on this slide. If you don't respond to a post-pyloric trial feed, you won't respond to fundo. That actually seems pretty definitive, but it doesn't come through in the guidelines. And was there another reason that these weren't as strongly emphasized in the guidelines?
Yeah, that's the Rosen guideline at the end. That's not part of the original guideline. The reason that it didn't make it into the guidelines was because of just exactly like you said, a complete lack of evidence in the literature. So we know that with post-pyloric feeds from studies that we've done at Boston Children's, that with GJs, you get your number of reflux episodes down to about 15 to 17 episodes per 24-hour period. And that's on par with what the post-fundoplication impedance data looks like. So if you kind of match up the data, the number of reflux episodes with GJs matches that of Fundo, but I think there's enough data based on impedance studies, post-pyloric feeds, that I think it's worth doing.
All right, this is awesome. We're going to go on to the next topic, which is about medication. So I'm going to show your next slide. You've kind of brought up.
As everybody knows, acid suppression is kind of the go-to. For infants, there's no data to show benefit for them. And I think, again, largely it's because these kids are refluxing milk. So you can put all the PPI you want in them and it's not going to stop the milk from coming up. Now we're doing PPI genetics. So when we have patients who aren't responding to standard acid suppression doses, we are checking their CYP2C19 genetic status to see how they metabolize the PPI to explain why they're not responding. And for sure, now we're getting lots of questions from families about bone health and infection risk. The motility medicines, we think about erythromycin, we use a lot, despite the fact that there's no study to show that it reduces the number of reflux episodes. It may reduce the amount of full column episodes. So if you care how much is going to the airway, a macrolide is a good way to go. Prucalopride is our new go-to drug. It's approved for constipation in adults, but it has gastric emptying and reflux benefits. So we're starting to use that more. And then of course, some institutions can get cisapride. So that's motility meds are still on the table. And we talked about feed modification, and I just want to highlight the blenderized feeds, because when I think about like one thing that has changed the field of pediatric gastroenterology more than anything in the last 5 years, I think it's the widespread use of blenderized feeds. So now in patients who have G-tubes, we're running their feeds super thick. Blenderized feeds, we just take food, put it in a blender and put it in the G-tube instead of formula. And we're pushing viscosity in those patients. So that's a big change. And then there's some other things, like I mentioned, pyloric Botox we use a lot of. Now the adults are using bile acid sequestrant. So for your patients who have lots of bile reflux into the stomach, who have duodenal atresia, for example, we will use bile acid sequestrants. And then we talked about the post-pyloric feeds.
If the medication also does not work, then is that when you would seek surgical consultation?
Yeah, I think it depends on what else is going on. And as you heard, if the baby's thriving and there's no respiratory issues and things like that, I think all of us would hesitate to do that. But if you're seeing complications from the reflux, then I think it's a very reasonable next step.
I would agree with you. I think that would be the standard at our institution as well, that on a patient that does not have failure to thrive, we would be hard pressed to be very aggressive about doing a fundoplication. So I think, Sharif, you've given us a great transition back to your perspective north of our border about how you take care of patients with reflux disease.
This is a paper that we're all familiar with that looked at decision-making on the part of surgeons. And the conclusion is that these data suggest that a surgeon's final decision to perform an anti-reflux procedure may be just as influenced by non-objective factors such as referring physicians and parental opinions as it is by objective studies. Now, anybody watching this should be very disturbed. We did this study a few years back looking from a critical standpoint at the literature, and the amount of bias in the literature was absolutely overwhelming. We simply have no good literature, and Rachel mentioned that earlier, and even when we get to guidelines and so on, that we're still depending on very poor literature. And again, we know these publications from our gastroenterology colleagues, from our APSA colleagues. I read this again, just as most of you probably did before this session, and the most common word is poor evidence, unavailable evidence, grade 4, etc. Even in these very amazing efforts at reviews, we still can't come up with something that can clear the fog. This is actually one of the better quality study, a prospective, very excellent follow-up study of infants who had feeding problems. About half of them had comorbidities, so even worse than the patient we're discussing, and the other half did not. And all they did in patients who failed all other interventions is put a gastrostomy. No GJs, no fundoplications. 90% of all patients improved without need for any other maneuvers, and about half of those had their gastrostomies removed shortly after a year. So I think it's more of an issue of giving nutrition and feeding rather than trying to control reflux. And I emphasize again, I think we're overdiagnosing it regardless of what we do. But this is a study that was just published last month, and I thought it was impressive. These are the type of studies I think we need to be doing. Good prospective follow-up studies in the absence of the ability to do randomized trials.
So we would probably come down on the spectrum as an institution that favors doing an anti-reflux operation when babies have what we view as pathologic reflux. But the pendulum has certainly swung back in the other direction. We don't do nearly as many fundoplications as we used to.
Talking about who would be a good candidate for a GJ tube, I think patient selection is very critical. I don't think there's an ideal candidate. There's certain patients who I do think would be better candidates than others. I think it's not the panacea for sure. The way I think about it is that kids who have a poor feeding status by mouth or a poor probability of success outcome of feeding at starters, or have a great risk for aspiration. All those kids with laryngeal clefts or kids with just bad baseline prognosis for oral feeding is one thing to consider. Kids with esophageal motility issues, particularly, is some that you may want to start with that. I'm not saying that a GJ is going to be the only thing that patient's going to have, but I think it's a great start to kind of tease out the situation. Particularly, I think our biggest cohort of GJs is the cardiac patients who you anticipate that this feeding intolerance is going to be short-lived, a few months or a few weeks. I think this is a great sort of crutch to get them through that episode. Also, other kids who are very high risk for an anesthetic or multiple prior operations, or kids who already have a G-tube. It's fairly straightforward to convert a G-tube to a GJ tube. You do have to keep in mind that most kids with a J-tube feeding style can't be bolus fed. Other patient population is patients with motility issues of the stomach. So some kids with gastroparesis that need sort of post-pyloric feeding regardless, and some sort of gastric venting or drainage capability that, or a patient who's had a fundoplication already and doesn't appear to have a mechanical reason for the wrap to fail, but still is having issues and needs post-pyloric feeding. Or if they did have a wrap failure, but they don't want to undergo a reoperation, or if the risk of a reoperation is too high. So I think these are candidates that I think the decision for a GJ should be strongly considered. I don't think it's an absolute indication, but I think it's important to consider that. I think what has been encouraging with the GJs is sort of trying to understand a little bit the natural history of the GJ tubes and how many of these kids actually get off the GJ feeds and go on to G feeds, so to speak. And some studies vary, but broadly speaking, it appears that of those who start with a GJ tube, about 10 to 20% ultimately undergo a fundoplication. So it is a way to diagnose those who will ultimately benefit from the fundoplication. But the majority are able to transition to gastric feeds in sort of a period of 6 to 8 months, and some even includes a transition to oral feedings depending on the underlying circumstance. So the idea is that it's a temporary situation. Annoying factors are that, yes, that they can get clogged and get dislodged, and they can also leak. And so most need replacements over sort of 3 to 4 month time frame. Most of these get scheduled. There has been some studies that talk about whether if you wait for problems to occur versus sort of scheduling exchanges, it appears that if you have a strategy of sort of scheduling exchanges, you will have less of a off hours or weekend, or it becomes less costly to manage the admissions just for a GJ tube exchange. Most of the replacements can be done without general anesthesia.
How you have the conversation with the family when you're talking about surgery. Let's say everyone's on board with some sort of anti-reflux procedure.
I think the families like a couple things. I think that they like the fact that it's not a permanent, so to speak, change to the anatomy of the upper abdomen, so to speak. The other thing that they like is that they can switch between, it's an easier transition to switch from a GJ to a G, and then if it's not working, back to a GJ. So they like that possibility to change things around. They don't necessarily love the idea of having to change it every 3 or 4 months, but they understand that it's better to change it before it causes problems with clogging and dislodgement, as opposed to having it to happen on a Saturday night and being stuck with that at home. So,
do you have a minimum? I know some of the complications that have been documented of these GJ tubes have occurred in the really small babies. Maybe, we at Emory here, it's not uncommon to have the 2.5 kilo cardiac baby. And there have been concerns in the past about the size of those tubes or the flexibility of the tips. There may be some new ones that are out there now. Can you talk a little bit about that?
Oh yeah, size and patient weight, I think, is critical in terms of the type of tube you choose to place and where you how you place it and where you leave the tip of the J tube. I think those are key. And so there's been several studies that have looked at this risk of intestinal perforation. That often happens not necessarily at the time of the placement, although it certainly can happen at the time of the placement, but often happens in the first week after the placement. And I think it's related to what you said, that the jejunal limb being too big or too thick or too stiff at the tip, putting pressure at a fixed location. Most of those happen at the ligament of Treitz, and they happen usually within the first week of placement. I think it's just a matter of pressure in that area. And so the modifications that have occurred because of that is we've sort of initially made the 14 French sort of size that it has with the gastric and a jejunal limb. We modified it to thread thinner sort of feeding Corpac tube through that jejunal limb. Instead of it, the standard that comes off the box is I think around like 10 French, bring it down to a 6 French. And so it's a much thinner profile. The other big thing I think to consider is to place the tip of that tube either proximal to ligament of Treitz, so just barely postpyloric, kind of like in the D2 region, or really make sure that it's going and making that turn heading down postpyloric. What you don't want to do is leave the tip right pointing upwards, almost like toward the diaphragm or toward the spleen, because that invariably is going to be the ones that are at risk for perforation. If you're careful about where you place them, we've had less issues with that in kids. I think the highest risk is definitely those under 5 kilos. But I would even consider that these modified versions for those that are under 10 kilos. After 10 kilos, I think you can go with the off the box, sort of thicker ones, which I think are easier to manage as well as an outpatient. That get clogged. The clogging issues are definitely related to the size of the jejunal limb. The other thing to consider is the thicker the tube in the small babies, they can also lead with issues with intussusception around the jejunal limb. And so some kids who've had feeding intolerance post GJ tube placement, something with an ultrasound, we got to check that there isn't an intussusception around the J tube limb, which responds nicely to just taking the jejunal limb out.
Is there a patient population then that you see that Nissens would be beneficial over the GJ?
I think so. I think if there's a structural issue, a particular hiatal hernia, or somebody who is a good feeder by mouth, then this doesn't really make a whole lot of sense for them. If you're able to fix the reflux or the underlying condition, this particular hiatal hernia, then I think that particular kid is going to be better suited with a fundoplication.
You know, similar question that I had for Ben would be how you phrase the conversation with the family a little bit and how you think about the risks and benefits of the Nissen versus the GJ.
I was sort of taking a couple of notes as we were sort of sitting here listening. A little bit of this is tongue-in-cheek, and I'm playing devil's advocate, but I do have to say, first of all, I do think there is a time and a place for a GJ tube, but it's hard, I think, for me to compare them head-to-head with equipoise because of the following things. If I look at these and I'm talking to the family and I'm sort of comparing the two, I say, okay, with one, you get a definitive operation up front. You can retch through the Nissen and you can have recurrent reflux. But with the other, you're guaranteed to have a readmission every 3 months or so. There's not anatomic disruption with the GJ tube, but I would argue, at least from adult data, we know that fundoplications do come undone over time. With babies, because if they're not having symptoms, you're not necessarily going to do an upper GI and look and see if they have shoulders there that are showing a persistent wrap. But if the adult data is any indicator, it would tell us that our fundoplication is not a permanent alteration of the anatomy of the stomach. With a GJ tube, you're tethered to a tube. You're going to be doing continuous feeds. And even though it may be temporary, and then you can switch to bolus feeds after 6 to 8 months, that family is carrying around a pump for the next 8 months. They compare that with a baby that can go on bolus feeds and they can take the kid out. When we talk about complications, the things that you mentioned, I mean, the minor things like dislodgement, sure, that's an inconvenience and a headache and you're taking off work, but some of these other things, perforation of the duodenum, perforation of the retroperitoneum, erosion into the spleen, intussusception around the tube, all of these things are things that we create by putting a GJ tube in, and none of those exist with a fundoplication. So I don't want this to sound like I'm a hardliner as if to say that fundoplication is the only way. I think that you have to be very upfront with the family when you're talking to them about the implications for their life and, you know, their day-to-day activities long-term, or at least 6 to 8 months after an intervention. That the families that are dealing with this constantly, They're the ones that really have to know what the implications are on their day-to-day activities.